Thank you for joining us this evening for our virtual education event, Prostate Cancer Risk Factors and Screening Recommendations. If you have any questions during this evening's event, please post them in the Zoom chat window, and we will address them during the last 10 to 15 minutes of the event. If you have any questions after this evening's session, please feel free to email them to outreach@capecodhealth.org, and we will follow up with you directly. We also encourage you to visit us on the website at capecodhealth.org/prostate awareness to learn more about prostate screening, treatment, and prostate cancer risk factors. So I'm excited to join you all tonight for this virtual event and discuss prostate cancer screening and how we go about diagnosing men with prostate issues in general, in addition to cancer. I have no conflicts of interest that are pertinent to this talk. So let's talk about some of the numbers behind prostate cancer. Prostate cancer is the leading or the most diagnosed cancer in men. So as you see over the next year, about 1 million over 1 million patients will be diagnosed with cancer in general, and prostate cancer will be about 30% of those, or over 300,000 new cases. It's still the second leading cause of death in males, even though it is the most diagnosed prostate cancer or most diagnosed cancer in men. So that has a lot to do with the fact that there's a lot of prostate cancers that are very easily treatable, and that there have been many successes over the years with our treatment. So what is the prostate? The prostate is a walnut-shaped organ that sits between the bladder and the base of the penis. It is responsible for the ejaculatory process, where sperm from the testes will come into the prostate through the vas deferens, and then it'll get mixed with a series of fluids from the prostate and the seminal vesicles. So let's talk about the typical patient that we see and evaluate for prostate cancer. This is a 63-year-old healthy, active man who meets with his primary care physician for his annual physical. Of course, he's on a sailboat like most Cape Codders. He has an older brother that was diagnosed with prostate cancer at age 68, and he's wondering about his particular risk factors for prostate cancer and how they can be addressed. So we talk about prostate cancer screening. We're mainly talking about a test called PSA, or prostate-specific antigen, and also digital rectal examination. So I'll talk a little more about screening and what you should know. So most prostate cancers are really asymptomatic. In the early stages, many men will feel no particular symptoms. In the intermediate stages, they may cause problems with urinary flow. So you may feel increased problems urinating, a weak flow, frequency, meaning that you need to go often, and maybe some pain or burning. There are a lot of other non-cancerous problems that can cause these types of symptoms, like prostatitis and benign prostatic hyperplasia, or also known as BPH, the enlarged prostate that many of us are familiar with and maybe are dealing with on a day-to-day basis. In high-risk stages, there can be more symptoms, such as dull pain in the pelvic area. Sometimes there'll be blood in the urine, painful ejaculation, pain in the hips, lower back or upper thighs. This may have to do with things like bone lesions or spreading of prostate cancer outside of the gland itself, and then loss of appetite or weight loss. And again, this is usually for people that have very advanced disease and that's gone well beyond the prostate. Blood in the urine can be caused by many other things, and actually it's usually not prostate cancer. So as an aside, if you ever do see blood in the urine, please take that very seriously and talk to your primary care doctor or schedule an appointment with a urologist to have that worked up, especially if it's something that comes with no symptoms at all. So as far as initial screening for prostate cancer, we like to talk to our patients about why we screen and how we're going to screen. The patient and either their primary care doctor or their urologist should talk about when, how, and what we're trying to learn from the screening process. And essentially, both parties should feel comfortable with proceeding with the screening process. Generally, we recommend by our guidelines initiating PSA or prostate cancer screening at age 45 to 50 years. And that's in people who have regular risk factors. In people that have elevated risk factors, then screening should begin earlier between the ages of 40 to 45. And I'm just highlighting those points I just talked about. Now, what are some of those risk factors? So anyone that has Black or African ancestry have an increased risk for developing prostate cancer. There are certain types of genetic mutations, and most of us have heard about BRCA1 and 2 mutations from maybe family members that have had breast cancer. And there is some overlap in some of these genetic issues and prostate cancer. And then anybody that has a strong family history of prostate cancer should certainly have the discussion about screening. This can include anybody whose brother or father have had prostate cancer, and anyone who's had 2 or plus male relatives that have had prostate cancer. So we go back to our vigorous healthy Cape Codder here, who discussed the screening process and agreed to move forward with the PSA blood test and the rectal exam to screen him, to start the screening process for prostate cancer. Now, as far as the PSA test, the PSA test is a blood test. It was a protein isolated in 1979 and patented in 1984. It was introduced into clinical practice in the 1990s. Now, a really important thing to remember about PSA, or prostate-specific antigen, is that it's not made by just cancer cells. PSA is a naturally occurring enzyme that all men have throughout their lifetime, and the only thing it does is that it liquefies semen. So it is it's something that can be that we use for prostate cancer, and I'll explain a little more why. But you have to remember that just having PSA in your system is not a bad thing. It's not it's not a source of malignancy just at the outside, and I'll talk a little more about how we differentiate that. So they looked at, PSA levels in men over a course of 45 patients who underwent radical prostatectomy. They looked at their PSA levels, and this was one of the hallmark studies that went on to validate the use of PSA for prostate cancer screening. And in general, they showed that men with prostate cancer tended to have higher PSAs. Now, the reason why that happens is that prostate cancer is essentially an overgrowth of prostate glands. The prostate gland cells make the PSA. So most men will make PSA at a kind of a constant rate, and a lot of times will increase over the years as their prostates get bigger. But when you have prostate cancer, there are more cells, and hence more cells are making the PSA, and the PSA tends to go up. Prostate cancer cells in general will make less PSA per cell than a regular prostate gland, but with more cells, more PSA. So that's why we use it for the screening purposes. As far as the rectal exam is concerned, most prostate cancers, or in general, over the years, it's been thought that felt that most prostate glands will generate in the peripheral zone of the prostate. And the peripheral zone is sort of on the back side of the prostate, up against the rectum. Transitional zone, which is another part of the prostate that sort of sits around the urethra, develops cancer at a lesser rate, although it still does develop the cancer. But it's felt that most cancers, or a lot of cancers, can be felt through the rectal wall and in the prostate. And essentially what it feels like is, if you think about the prostate kind of feeling like a firm rubber ball, it feels like someone took a rock or something really hard and stuck it into that rubber ball. So when your doctor or when the urologist checks the prostate, they're checking for that rock hard area. Sometimes we'll also look for some asymmetry in the prostate, although that's certainly less specific than those rock hard nodules. Now, even though someone may develop a nodule or have a hard area, that doesn't mean that they have cancer. So it still means that we have to go through further testing to determine whether it's prostate cancer or not. So just having an abnormal exam is not not proof that there is cancer there. And again, it's not recommended as the only screening tool. Again, we use that in conjunction with PSA and other tests that I'll talk about in more detail later. And that shows us where the prostate is and the examiner's finger up against the prostate, feeling for those nodules. So our patient had an enlarged prostate, but no nodules or suspicious areas identified. His PSA was 5.7. And what are we going to do about that next? So as far as a high free PSA, PSA across the board is considered to be high if it's over 4.0. Now, there can be some variations in that theme, which we'll talk about in more detail. I always repeat the test. I will almost never, and I hate to use absolutes in medicine, but it would be very rare for me to recommend a biopsy based upon just one PSA result alone, because there can always be false positives. People can have elevated PSAs because of inflammation, infection, if they had recent surgery, if they had a Foley catheter placed for whether it was part of an operation or whether they had another illness that required the catheter to be placed, and even just having a large prostate in general and having all those glands making PSA can result in an elevated PSA. As we get older, as I mentioned earlier, we can see that our PSAs may rise on their own, and may have a benign rise over time, just based on our prostates getting bigger and getting older. So people have looked at age-adjusted PSAs, which this graph or this table kind of shows that, for people between the ages of 40 to 49, we would expect that their PSAs should be lower than that sort of all-encompassing cut mark of 4.0. For people in their 50s, a PSA less than 3.5 would be considered normal. And then as we get older, 60s, 4.5, and then up into our 70s, 6.5 and below could be considered normal or when I say quote normal in this population. We can also look at PSA velocity. This is another thing that we can look at. So even people that have very low PSAs to begin with, so say our index patient that we talked about, his PSA had been 1, 1.1, 1.2, 1.1 again, but then suddenly jumps up to 3. And so normally I would check that again on a short interval and see if it maybe goes back down to normal. But if that PSA velocity gets up over 0.75 per nanograms per milliliter per year over an extended period of time, say 18 months or even longer, then that's when my suspicion may be raised a little bit. As far as our index patient, no nodules, suspicious areas, PSA was 5.7, and we repeated the PSA and it came back at 5.8. Well, what can we do next? There's more things that we can do. We can look at something called free PSA. So there have been studies that looked at the amount of bound to unbound PSA in the bloodstream. And when I say bound PSA, it means that PSA that are bound to some of the proteins in the bloodstream. And they found that when there's a higher percentage of free PSA or unbound PSA, then that can most of the time that correlates with a benign elevation in PSA. And there's different nomograms and tables that we can look at with those PSA levels or those different PSA free PSA percentages that can give us a variety of risk calculations as far as whether the PSA. So in our last patient, if his PSA was 5.8 and say he had a 30% free PSA percentage, then his risk calculation would tend to be somewhat lower. Now, if his PSA was 5.8 and he had a 10% percentage of free PSA, then that may be a little more worrisome and would calculate to a higher risk of prostate cancer. There are a series of new biomarkers that have come out over the last several years as far as urine-based tests and blood-based tests. So there's a couple tests called 4K PSA, 4K score, or ISO PSA, and they use PSA in conjunction with several other biomarkers, and they have usually a proprietary nomogram or a proprietary risk calculator that they use with the PSA and these other biomarkers to basically give you another risk calculation as far as the expected chances of finding prostate cancer based upon those tests. And those are tests that a lot of urologists will use in conjunction with PSA to help sort of refine that risk calculation in better detail. There are a couple of urine-based tests called ExoDX and Select MDX, which are tests that we get from the first 20 cc's of urine that the patient voids, and in that first 20 cc's will be little bits of DNA and RNA or other chemical markers that are coming from the prostate that are put through a proprietary calculator, and we can come up with more estimates of whether we would find prostate cancer or not. Prostate MRI is a tool that we've been using extensively now for the last several years. The nice thing about the MRI is that it gives us a couple things. So first of all, it gives us a pretty accurate measurement of the prostate. So when we look at the size of the prostate, if somebody has an extremely large prostate with an elevated PSA, well, then we can say perhaps the PSA is elevated because it's just proportional to a very large prostate. If the prostate is small and the PSA is very high, now we're a little more suspicious because we're expecting a lower PSA based upon a smaller prostate. The other thing it can do is it can look at different lesions in the prostate, or it looks for the way that water moves through the prostate. So essentially, water moves through the prostate through regular prostate differently than through cancerous tissue. So the MRI can identify these areas and can tell us whether there's an area that looks to be of higher suspicion than the rest of the prostate. The way that that's helpful is that it can give us an idea of where we might do some extra biopsies and how we can hone in. In our office, we have a system that can actually map out these areas and essentially overlay them with the ultrasound that we use to guide our biopsies. And we can target these spots directly and try to make the biopsy more efficient. So again, speaking more about biopsy, this is the way that we actually diagnose prostate cancer. So the transrectal ultrasound prostate biopsy has been the gold standard for the last couple decades for diagnosing prostate cancer, and the ultrasound is used to get an even spread of biopsies from around the prostate. So and hopefully this doesn't sound too childish, but I kind of use the analysis of playing Battleship. Essentially, we do biopsies in an even pattern around the prostate, and we see if we hit anything. And with the MRI, it's allowed us to maybe take that grid and make it smaller and get more biopsies from the area where it's more likely that we would find cancer, and make it more likely that we see something when it's there. Transvaginal perineal biopsy technique is another technique that we can use to obtain biopsies. Instead of going through the rectal wall, we actually go through the area called the perineum, which is the area of the skin between the scrotum and the rectum. And there are some benefits to that process, include a decreased risk of infection. The drawbacks is that at least here locally, it requires general anesthesia, and there's definitely more sensation because there are more pain receptors in or the reason we do it while people are under anesthesia is because there'd be more sensation trying to do it through the skin. But it's just another way of another tool that we can use to help diagnose patients with prostate cancer. So brief overview of some of the treatment options and localized versus distant or metastatic cancer. So essentially, prostate cancer is graded on a scale of 3, 4, or 5. It used to be 1 through 5, but the patterns, which is what the patterns of cells, which is what the numbers correspond to, the pattern 1, the pattern 2 really aren't considered to be cancer anymore. So essentially, the pattern 3, 4, or 5 is what's considered cancer. And this is what I'm talking when I talk about the pattern of the cells is what the pathologist will see under the microscope. And what they do is they take the pattern they see the most and the pattern they see the second most, and they add them together to give you what's called the Gleason score. So when we get our pathology reports back, and if the patient is diagnosed with cancer, then the lowest score they can get is a pattern 3 plus 3, which also corresponds to grade group 1 that I have on the chart here. And then you can have pretty much any variation in between of the different pattern. So you can have 3 plus 4, 4 plus 3, 4 plus 4, etc. Anything that is 3 plus 4, meaning that it's predominantly 3, but then has some Gleason 4 in it, that's grade group 2. Grade group 3 is 4 plus 3. And then higher risk cancers are anything that's 4 plus 4 or above, or has any component of Gleason 5 in it. And in general, when we look at counseling patients towards different treatments, many times, or at least over the last, I would say, decade or so, we become more and more aggressive at pursuing an active surveillance technique for patients that have low risk and low volume cancer. And when I say low volume, I mean that maybe you had 1 or 2 cores that came back out of the 12, or possibly even more biopsy specimens that we took, 1 or 2 that had cancer in them, and only a little bit of that core was involved with cancer. And this is a strategy that we've been using effectively for the last, like I said, last decade or so, where there's a certain subset of patients that will have low risk cancer, and that depending on age and other other health factors, people that have low risk and low volume cancer that will never progress to anything that will ever hurt them or kill them. And it's generally patients that have Gleason 3 plus 3 cancer, maybe patients that have 3 plus 4, but only a small amount. And that's what we, at that bottom of the box there, that favorable intermediate risk, where maybe there's just 1 or 2 cores positive, and their PSAs are less than 20, and ideally less than 10. Like I said, just a little bit of that intermediate risk cancer, of that favorable intermediate risk cancer. Mostly Gleason 3, but maybe a little bit of Gleason 4. Patients that are higher risk, so people that have many cores of Gleason 3 plus 4 or higher than that, and maybe have disease that we can feel on our exam, then in most of those patients we would recommend going on towards staging and then likely some form of treatment. As far as the different tools that we use for staging, PSMA PET-CT has become a tool that we've been using very often. It's a tool that has given us higher sensitivity for finding prostate cancer outside of the gland after that initial biopsy. And basically, it's a PET scan that uses a tracer that essentially goes out and finds that prostate-specific membrane antigen, and is basically can find very low levels of cancer outside of the prostate. And it's just one of the tools that we've been using more and more over the last couple of years to help us figure out if people have disease that's outside the prostate. People are found to have prostate cancer that's just confined to the prostate alone. Essentially, the two main options, the two options that most people will go with, include surgery, removing the prostate, and that usually will include sampling the lymph nodes from around the areas where it's most likely that the prostate would, or the prostate cancer would come out of the prostate and land in those first areas where they drain the prostate gland themselves. And then radiation is another option, where sometimes people will go on to treatments called hormone blockade, where we essentially kind of shut down the testosterone producing ability of the patient to help make that radiation more effective. Prostate cancer is generally, especially in the early stages, is generally a hormone sensitive tumor. So when the testosterone is blocked, when the testosterone is cut off, it will sort of halt the prostate halt the prostate cancer in its tracks, and sometimes even it'll regress to some degree. And this is a picture of a PSMA PET-CT showing some of those areas that are lining up include some of the salivary glands up towards the top of the picture. Those are the kidneys all lit up kind of in the middle of the picture. Down the bottom is the bladder, and then the prostate underneath it. And these arrows are showing areas where there's some concerns for prostate cancer outside the glands, and some of the lymph nodes where we normally see where we may see that those first landing spots for prostate cancer if it gets outside the gland. In general, for metastatic prostate cancer, most of the time we would consider blocking the hormones with basically what we call chemical castration, or medicines again that block that production of testosterone. There's also several other new medications that have come out over the last few years where they either block the testosterone receptor or block the production of testosterone in sites outside of the testicles. So it really, for people that have just a little bit of testosterone being made elsewhere in the body, it will help block some of those other areas and get that testosterone super low. Chemotherapy has come out as also a primary option for people that are newly diagnosed with metastatic prostate cancer. In the past, we generally waited for people to basically become hormone resistant, which is kind of a whole other talk. But we found that chemotherapy up front can help increase survival for people that are diagnosed with advanced prostate cancer to begin with. So back to our patient, he had an enlarged prostate, no nodules, suspicious area, PSA was 5.7, 5.8. He had an MRI that showed a small lesion within the prostate, suspicious for cancer. He did go on to have a fusion biopsy, or a targeted biopsy to target that area, and he was found to have Gleason 3+3 in 3 out of 15 cores. And he was considered to be low risk. In people that have, he was considered to have greater than 10-year life expectancy, and for people that's generally sort of our general litmus test as far as depending or trying to decide how aggressive to be with treatment is if somebody has a lot of other medical problems and have a lot of other battles to fight outside of prostate cancer, then sometimes the prostate cancer will just need to take a backseat to everything else that's going on. But again, for this gentleman, these three options were all offered: active surveillance, surgery, or radiation, and he elected to proceed with active surveillance. When people go on active surveillance, they will generally go on a regimen of PSA checks, regular prostate exams, and then biopsies on a regular basis as well. In general, I would do a confirmatory biopsy or a follow-up biopsy at the 6 to 12 month range, depending on what their initial pathology showed, what their PSAs do after the fact, and what their exam does after the fact. And essentially, how suspicious I am based upon a whole bunch of other clinical factors and experience, as far as how nervous I am about them developing something more than just low-risk cancer going forward. The other options, as I mentioned before: radical prostatectomy, taking the whole prostate out, radiation, and these are all things that are offered here at our beautiful facilities. I'm sure you all recognize Cape Cod Hospital. Our office is down in that picture to the right, which shows our new office, which we just celebrated our 1-year anniversary, and it's been a very nice space to offer our biopsies and all the screening techniques that we talked about earlier. And then, of course, the new Barbie Pavilion, the new home of radiation oncology, another beautiful new facility. And again, we offer essentially the surgical approach that most surgeons are offer around the country. More and more surgeons, I would say the vast majority of people that have radical prostatectomy is done through the robotic technique. There are a few open surgeons still out there, but most of them are, I hate to say aging out, but the vast majority of surgeons coming out of residency these days are trained in the robotic techniques, and that offers offers some significant advantages over the open technique, as far as recovery, things like blood loss. But we have the XI robot here, and also a fellowship trained robotic surgeon, Dr. O'Rourke, who gave this talk last year, who is really taken off as far as his experience level, and is offering the surgery and doing a great job. So with that, I'll try to wrap up, or I'll start to answer some of your questions. So thank you for your attention. So Our first question is, how can a suspected prostate cancer biopsy be executed without releasing cancer cells into the wider prostate or bloodstream? That's an excellent question. It's something that I'm often asked. Um, the quick and dirty answer is we really don't know how much is released into the bloodstream, but basically I would say the vast majority of prostate cancer is diagnosed through the biopsy. So there really is, other than a TURP, which is a transurethral resection of the prostate, where the tissue is taken from um, from a transurethral technique rather than through the needle biopsies. Essentially, any way that you're going to be able to get tissue, you're going to have to release, uh, in theory, release some cancer cells in the bloodstream. So it's either a biopsy or a TURP, or you just would never know. Um, that being said, the treatments are, not any simple matter, and come with some morbidity and risks. So treating prostate cancer without a biopsy was something that we would really only do for people, very select cases, and usually people that are too sick to withstand biopsy or undergo any kind of other significant invasive treatment for prostate cancer. So in general, I agree that yes, in theory, one would think that prostate cancer would or possibly could be released into the bloodstream. But um, the I guess the short answer is that there really would be no other way to diagnose the prostate cancer otherwise. Um, how treatable is prostate cancer caught early? As I showed in the first stage, or that first graph, even though prostate cancer is the most commonly diagnosed cancer in men, it is not the leading killer in men. So in most cases, it is very treatable if caught early, and it's also very treatable if caught late. Most of the people that are diagnosed with metastatic prostate cancer still live for many years afterwards with some of the other treatments I talked about, including the chemotherapy, hormone blockade, some of the newer hormone receptor blockers that we have available. So even at all stages of prostate cancer diagnosis, there are a lot of treatment options available. So we're excited about the advances that are being made every day, and it's a reason why it's all obviously finding something earlier, and when it's confined to the prostate gland, is going to give us a better chance of complete cure. So I think a better question is that when caught early, we have a much higher chance of, or I guess a better answer would be that when prostate cancer is caught early, we have a much better chance of curing prostate cancer as opposed to keeping it or treating it and keeping it suppressed. And are there any lifestyle modifications you recommend to help reduce prostate cancer risk? Nutrition, exercise, stress, etc. This is a great question and something I'm also asked very often. I would say that we have found that over the years that the things that are commonly associated with prostate cancer are associated with all cancers, which can be anything anything that's bad for your body in general. So diet, exercise, a healthy lifestyle, all these things help with all cancers across the board, but it's also found to be helpful with prostate cancer as well. There have been several studies looking at things like lycopenes and selenium and a lot of other types of dietary modifications. A lot of those things have, not a lot of those things are found to have a lot of evidence to suggest that they help, but we do know that reducing your body mass, or your BMI, your body mass index, getting a regular exercise, sleep, all these things that make you healthy in general will help prevent, or try to help prevent you from having serious prostate cancer, and are just good for everything in general. Okay, and to wrap up, If you have any questions after this evening's session, again, please feel free to email them to outreach@capegodhealth.org, and we will follow up with you directly. Also, feel free to reach out to our office. We're always happy to see new patients, and if you have any urologic concerns, we'll work with you to get you in and have you see one of our urologists. So thank you for your attention and have a great evening.